Hi everyone, very good evening. Welcome to our Friday webinar series. This is Dr. Prasad, consultant emergency medicine at Yashoda Hospital, Hyderabad City. Today we bring you yet another interesting topic, the approach to Wheeze, which is a very common presentation to our EDs every day. So to speak on this topic, we have a very eminent speaker, Dr. Safia Syed. So over to you, ma'am.
Okay, hello everyone. Thanks for joining the webinar. I'm Sophia, one of the ANE trainees at Leeds Teaching Hospital. So let me start sharing my slides with you.
Yeah, slides are visible.
Yeah, so my slide is visible. Okay, as you can all see, it's all about a Wheezy child. So today in this session, we talk about the assessment and management of these children. It can be bronchiolitis, wheeze, or asthma. Let's get started. Why is it important or why does it matter? And as Dr. Prasad said, Wheeze is one of the most common presentation in a pediatric ED setting. And in every shift, at least I see 1 to 2 patients presenting with Wheeze. And it's often overlapping, and the diagnosis is so uncertain. And often there are different management pathway for each one of it. The bronchiolitis has got its own guideline and pathway, asthma has its own, and viral wheeze. It kind of overlaps with asthma, if I have to say. And there is always a risk of over treating and bronchio baby with salbutamol, which is total unnecessary, or under treating or missing a mild asthmatic child, and then it leads to other severe or life threatening one. So our aim is to confidentially differentiate between all these common causes of wheeze and apply our structured ED approach, obviously in line with the guidelines. RCAM has got real good guidelines in treating all these wheezy children and manage these children safely in the ED. Okay, let's just start with a quick case. A 10-month-old comes to you in the ED with cough, wheeze, and poor feeding. What would you do? Would you give a salbutamol? Just hold on your answers. We'll come back at the end of the session. Interestingly, practice varies a lot. So the major pick, if I have to say, fitting them in the right category, it could be from a mild to moderate or severe or life-threatening one, rather than sticking or jumping directly to the diagnosis, because categorizing them, that actually helps us manage them better. We'll talk about each of this individually, but just having a broad idea about which age group they fit in helps. So bronchiolitis, bronchi babies in particular, usually present with their first episode in less than 1 year, but you can see bronchi babies presenting at the age of 2 as well, but broadly under 1. Viral wheeze can vary from 1 to 5 years, but they're usually episodic. This is an important bit which differentiates them from asthma. Viral induced wheeze are usually episodic. They present with underlying viral infection, very likely. Whereas asthmatic children, age group is more than 5, but their episodes are more recurrent than viral wheezes, and they can be often not associated with infection, and there would be interval symptoms like night coughs. The key in this slide is their response to salbutamol. If there is poor or no response to salbutamol, then it's highly bronchiolitis. And if there's good response, then it's a viral induced wheeze or asthma. Next slide, bronchiolitis. So by definition, bronchiolitis is basically the inflammation of laryngotracheobronchioles. Presentation, again, as I said, less than 1 year, can present till 3 years. It's been different uh, age group in different countries. US says could be 2 years. Again, UK versus India could be 2 to 3 years. And when do they peak? The peak symptoms are from 10 to 7 days. but the night symptoms worsen in 2 to 3 nights. That is the point where most of the children get their bronchi babies. They would be at the day 3 or 5 where the symptoms get worse. Usually from day 5 to 7, they start getting better. But warn them definitely that the cough can persist till 4 weeks afterwards. And what's the likely cause of bronch? The most likely cause of bronch is RSV, which is highly infectious. And bronchiolitis, as I defined earlier, is the inflammation. So the wheeze is mainly because of the edema and the mucus of the bronchioles rather than bronchospasm. This is an important reason why salbutamol does not help in bronchi babies. And even in less than 1 year, the receptors are not developed of the salbutamol. So definitely no salbutamol in less than 1 year. Moving to the next slide. What do you do when you approach a bronchi baby? It's a standard A to E assessment to everyone. But the important things which you have to focus on is the work of breathing. Are there any intercostal recessions? Is there any chest indrawing? Do they present with any tracheal drug? And are they tachypnic? How are their SATs? And how their feeding and hydration is? And if there are any signs of exhaustion that favor towards the life-threatening. So this is a classification of a bronchi babies. So based on the categories which I mentioned before. So mild babies are labeled if they are feeding normal, if the mom says, okay, the feet are up to the mark, be it bottle fed. It's always important to first learn about what their baseline feeds is. Moms and in general parents are very well aware of what their baseline feeding is, be it bottle fed, breastfed, or if they're weaning children. So I'll find out what their baseline is and ask them if the parents are happy they are feeding as usual. In that case, and if take the respiratory rates, if they can be mild tachypnic, if there is mild intercostal recession, but still they are not hypoxic, they are maintaining saturations, and the child is alert and there are no episodes of apnea, this child are in the safe zone, which is the mild category. Moderate category comes in when the child's speed is reduced to 50 to 70%, or they are slightly bit more tachypnic, and they are moderate intercostal recessions, and you can see prominent nasal flaring. But even these childs are not hypoxic. They maintain the saturations and there are no apneic episodes, but they can be slightly irritable. When it comes to severe, the feeding is being markedly reduced to less than 50%, or their marked respiratory rate increase, just tachypnea, and increase in work of breathing, severe recessions and grunting. These children even present with tracheal drug and head bobbing. So oxygen saturations are less than 92%. They are hypoxic and they possibility of apnea, and they look very tired generally. Life threatening is the one where the feet's being completely off, or any of the symptoms of poor exhaustion, poor respiratory effort, if they're markedly hypoxic, cyanose, they look apneic or drowsy and unresponsive. So based on this classification basically guides us towards the guide management. Sorry. Okay. So the children falling in the mild category are usually safe to go home. Any child who feeds more than 50% and saturations are more than 90%, they are good to go home. But always warn parents about expect the worst, which means they might have present to you during the day 3 to day 5 of their bronch. The symptoms can get worse from day 5 till 7, and then eventually they'll get better. But make sure, ask them to watch out the volumes, ask them to watch out how their feeding status is, if they are feeding appropriately, or are there any decrease in the feeds. Ask them to watch out how their nappies are. Maintain basically, ideally, it is like 1 to 2 nappies per day for sure. And ask them to watch the work of breathing, if there are any intercostal recessions, tracheal tug, and if they look the child has got poor respiratory effort, to get them back immediately. And it's worth discussing the parents about smoking. So it's generally advisable that to avoid smoking near the bronchi babies. Let's just go back to the previous slide. What do we do if the children fall in the moderate category where the feeds are reduced to 50 to 70, 75, but they're not hypoxic, they're saturating well? So, what do our management be in these kids? I wouldn't supplement them with any oxygen because they're saturating fine. There are no episodes of apnea, but feeds is something which is concerning. So these children need a bit more observation in the emergency department. You can encourage the moms to encourage them feed orally. If the feeding's been improved and the clinically the work of breathing gets better and they remain not to be hypoxic and the SATs are maintained, then these are the children who are fit to go home as well. Then who needs admission? Who needs PEDS review? All the children falling in the severe and the life-threatening category. So how do you manage the children falling in the severe category? We'll come back to this slide later. So the first and foremost thing is treat the hypoxia. Aim for the saturations 90% in more than 6 weeks or aim for 92% in less than 6 weeks. And next thing to focus is their hydration. RCM recommends NG feeds in the children who you think it's difficult to get an IV access because cannulating can make them more distressed and more CO2 retention and more falling towards a life-threatening or impending failure. So NG is equivalently beneficial and helpful. And would you investigate these children further? Would you do an X-ray? Well, in pediatric settings, always think of ALARA. If you think your investigation will change the management, then yes. If you think your investigation is not going to change the management, the answer is no. So in the bronchi babies, I would not recommend an X-ray because that's not going to change any management. Bronchi is all about supportive management, oxygen therapy, and hydration. Tap gas, yes, can be considered if you're thinking of an NIV if the child is falling in a life-threatening or whereas not coping up with the oxygen. Palivizumab is a monoclonal antibody, which we don't have to think much in the ED. It's basically by the PEDS team. By the time the child would need this, it's basically in the severe life-threatening cases, and the child would already be in the PEDS department or in the PICO. Viral swabs. Viral swabs are not mandatory to do in the ED setting. It's mainly towards the infection control, just for the source isolation. And let's go back to this slide. When we spoke about the mild to moderate category children who are good to go home, even if there are few children, this is the category of the children, irrespective of falling in the mild to moderate category, even though the saturations are fine, the feeding fine, but if any of this risk factor persists, they need speech admission. So which includes if they are less than 6 week old, or if they have history of X preterm, if they have chronic respiratory illness, pulmonary hypertension, any previous bronchiolitis episode where they needed CPAP or PICO admission, or if they have a history of immunodeficiency, inborn errors of metabolism, cystic fibrosis, and trisomy. It's just a copy-paste picture from RCM learning. Okay, hope bronch is clear. Let's move to viral Wheeze versus asthma. So how do we differentiate a viral Wheeze and an asthma? So the important thing here is history is the key. Viral induced wheeze, the trigger is, as I mentioned earlier, is infection. There are episodes where the child is completely well and wheeze free when the infection's gone. Whereas in asthma, the trigger can be exercise and they usually present with the symptoms of night coughs, and there could be some interval symptoms of coughings and wheezing with no underlying infection. And this is the classification of viral induced wheeze and asthma, which is same. So they're categorized into mild, moderate wheeze to severe wheeze and the life-threatening wheeze based on the speech, saturations, heart rate, respiratory rate, and again the work of breathing. They fall in mild to moderate category if they're talking in full sentences, if it's a verbal child, and saturations more than 92, heart rate less than 14, 1 to 5, and less than 125 in more than 5 years, and respiratory rates less than 14, 1 to 5, and less than 30 in more than 5 years. So basically, they're not hypoxic, not tachypneic, they're talking in full sentences, but they have these with very mild work of breathing. Severe category comes in where they're hypoxic, where the saturations are falling to less than 92. They're too breathless to talk or to feed. And if they're tachypneic and tachycardic with the numbers given here, and they have marked intercostal recession, tracheal tug. Life threatening, if any of these features are positive, they come under life threatening, which is could be a silent chest, could be cyanose, hypoxic. They could be bradycardic because of poor respiratory efforts. They could be exhausted, confused, and hypotensive. So this classification helps us guide the management. Let's move to the next slide of management. If the child falls in mild to moderate Wheeze category, what do? We start with 6 to 10 puffs via spacer. So they don't actually need nebulizers because they don't need any oxygen. So I would just go ahead with a simple spacer. APLS as a 6 puffs. Yes, you can go ahead till the 10 puffs as well. Sorry about my IT insufficiency. The next slide. So after giving 6 to 10 puffs of salbutamol, you reassess the child in about 20 minutes and see how it's going on. If the child clinically improves and the wheeze gets better and is not needing inhaler till 4 hours, then this child is happy to go home. If this mild to moderate, so we are just talking still about the mild to moderate category. If the child is needing inhaler earlier than 4 hours, then even the mild to moderate wheeze category child needs a ped review. Okay, let's go back to the bar slide. How do we manage a severe wheeze? Severe wheeze, aim for the saturations 94 to 98 and give them nebulized either with salbutamol plus ipratropium. So it's not either. It is salbutamol plus ipratropium bromides, which is a mixed neb. The doses are seen on the screen. Less than 5 years is 2.5. More than 5 years it is 5. Ipratropium 250 mcg in less than 12 years and 500 in more than 12 years. Give 3 such of mixed nebs. Ideally, you can reassess after every nap, but it's okay to assess them if they are severely busy at the end of 3 back-to-back naps. So you give them in combination. There's something new which is added. It's like adding magnesium 150 milligrams to each mixed nap can help, but again, there are questions about it's still a gray area whether it's actually beneficial or not. At this point, where you think the child is wheezy, you have given 3 mixed nebs, this is the time where I would apply Amitop. Amitop is basically a 4% tetracaine. It's a general UK practice where we apply it on the prominent vein so that it numbs the area and it's easy for cannulation. And what happens? You have given 3 back-to-back nebs, you have added magnesium to it, you have reassessed the child after 1 hour. If the child is again, saturations are improved clinically well, then after 1 hour, that's the point where you repeat the salbutamol nebs, and which means the child is clinically improving. You don't add any ipratropium at this point, but still this child needs a pre-review. It's just that they stretch from 1 hour till 2 hours and manage it till 4 hours. Till 4 hours, if the child is wheeze-free, then probably can be discharged from the peds team, but this definitely needs to go to peds again. How different is life-threatening wheeze managed? As an important point here, if imminent respiratory or cardiac arrest, please consider IM adrenaline. There have been cases of pediatric mortality where the anaphylaxis have been missed and treated as asthma. So that's why in case of always in doubt, respiratory or cardiac arrest, start with IM adrenaline till we get an IV access. If A life-threatening wheeze, if you're very sure and not in any kind of rest-like situation, the treat get an IV access, VBG. Yes, you might need an IV, but the nebulization treatment is as same as the severe wheeze, where you give three back to back and then reassess them. What happens if they don't get better with three back to back? Here comes the next slide. Then you consider IV magnesium sulfate and hydrocortisone. If the first line don't help, then you can consider IV aminophylline or salbutamol. Right? But this time you will have the PICU team ready with you to take over. Hope it's clear. These are the points which are to remember. Steroids are not ideally indicated in mild to moderate weeds. Prednisolone, give prednisolone only if the child is more than 5 years or if has got a history of atopy or interval symptoms inconsistent with asthma or if there's family history of eczema, atopy. Magnesium sulfate, either as a NEP or IV, is not licensed to be used under 2 years. A trial of bronchodilators could be considered, as I had mentioned, less than 1 year. The receptors are not developed for salbutamol. But if there's a strong history of atopy and eczema in the child, and there's a strong asthmatic history in the family, you can consider salbutamol and but review them within 20 minutes if there's any change. If there's no change, that's again just not going to make any sense. Stretching to 4 hours, as I had said, be it inhalers or nebulizers, make sure they are wheeze free till 4 hours before they go home and they're not needing any inhaler or any wheeze treatment less than 4 hours. And that's the time they can go home. And if they're scoring less than 2, always discharge the children with a wheeze plan and teach the parents the right technique how to use the spacer because that makes a huge difference. So, take home messages. Age and history are your biggest diagnostic tool. Always assess the severity first because that guides the management. Response to salbutamol can help you differentiate when in doubt. And importantly, bronchiolitis is not asthma, so avoid overtreating bronchiolitis. Yeah, thank you.
Thank you. That was a very lucid talk, and I'll check if there are any questions.
Okay.
Yeah, chat box is empty. So before we let you go, I have a couple of questions.
Yeah, sure.
Yeah. So basically, what is a clear-cut indication to use magnesium sulfate in all age groups? It's not only pediatric. In an adult, predominantly, what is an absolute indication to use a magnesium?
So if you're specific about in Wheeze, if they are
Yeah.
falling in a life-threatening category or if they're not improving with nebulizations, then definitely I would consider it. If they're getting worse anytime and not working out with back-to-back nebs, then that's a point I would consider IV magnesium. It's basically based
Okay.
on the clinical treatment, the clinical signs, and the
Response.
response to nebs.
Okay, fine. So although the literature is very clear, but in clinical practice it's slightly different. So
Yeah.
they don't go into a stepwise approach. They start all things at once. And the other one
Yeah.
is
Mhm.
the what is the immediate effect? Because steroids will not have an immediate effect in a wheeze. So why would everybody rush to steroid when someone presents with a diffuse wheeze? Is there any rationale?
Exactly. Practically, I've seen the practice. Like I've worked in the Pete's A&E here, and I don't see them rushing to the steroids immediately, unless there's a as I mentioned, if there's a strong
Yeah,
history of atopy, eczema, either with the child or if the child has responded to steroids previously, or if there is a strong family history of asthma. Only in that case, it's just for the bronchospasm, but ideally, that's not the first line. Steroids are indicated in the croup, whereas like mainly the upper airway rather than the
Yeah.
bronchiolitis or asthma.
Yeah, since you have practiced, I think 4 5 years in India, I think you would also have seen this kind of practice. So they
Yes.
immediately rush into steroids, although the
Yeah,
rationale.
but that's not the actual treatment. Yeah.
Yeah, because the mechanism of action itself is delayed because it's a steroid, it has to diffuse into the cell membrane and then take into action and all. It will take a little more time to act. But somehow the first thing that
Yeah.
any specialist would come and ask is the same thing: how was the steroid given or something? So anyway,
Exactly. The whole point, as I said, to relieve the bronchospasm in the viral disease or asthma. So
yeah.
they don't immediately act to relieve the bronchospasm, whereas it's the bronchodilators are the first line treatment anyway.
So how would you differentiate a wheeze from a respiratory wheeze from an cardiac wheeze? Any inputs on that?
Respiratory wheeze, well, that's a tricky question. I haven't experienced that much about it, or else, no, I don't think so. I don't have answer to this question, honestly.
All right.
Viral
I
wheeze
think
versus cardiac.
yeah, I'll just
I have not come across much. I've mainly dealt with the respiratory wheezes.
okay. Fine. Thank you so much for patiently answering my questions. And we don't have any questions from the audience, so we'll end it here.
Oh, all right. Thank you.
Thank you. Thank you so much for your time.
You're welcome.